Hello, my name is Michelle Morand. I am a precision cancer medicine educator and advocate, and I'm here today with Alexander Rolland, precision cancer medicine research specialist, and whom we affectionately call the cancer guy. And Alex is here today to talk about something that I asked him to prepare a presentation on because it comes up all the time in my conversations with breast cancer patients. People who believe that they've had tumor DNA sequencing when in fact they haven't, because they have an Oncotype DX result. So Alex is going to tell us a little bit about what Oncotype DX is, what it does look for, and the information it does give your doctor, and what it is not, and how you can make sure you have the most thorough and accurate diagnosis and the most effective treatment plan. Alex, tell us all about this.
Yes, there is a lot of confusion with patients about what an Oncotype DX is.
Yeah.
It's actually, a test designed to determine whether a patient's going to benefit from breast cancer, early stage breast cancer patient's going to benefit from chemotherapy or not.
Yeah.
Interestingly, it has developed over the years and it's been used in a few different contexts. So the test was actually quite a simple test, and it was designed quite some time ago. And since then, it's been validated in different approaches. So I'm just going to go over those. So it's commonly used. Many cancer agencies use it for breast cancer patients, estrogen positive breast cancer patients with a certain type of breast cancer in stage, and that's stage 1 to 2. It is specifically designed to indicate if you will benefit from chemotherapy or endocrine therapy.
Okay.
It's not tumor DNA sequencing. And so, you don't want to confuse the two. They have completely different purposes. So basically what this test does is it looks at 21 genes that can affect the outcome of a patient. Test measures how aggressive a breast cancer is, and it helps doctors decide on adjuvant, which means after surgery therapy, and if aromatase inhibitors, which is endocrine therapy, chemotherapy, or both are required. So typically the test has a score between 0 and 100. And once again, it's used for stage 1 to 2, estrogen positive. First off, we'll discuss lymph node negative cases, but it's also now being used in lymph node positive cases. So basically, it is a expression array. It looks at whether these genes are overexpressed and turned on at a high level or higher level or not. Basically, there's 16 known cancer-related genes and then 5 reference genes. The reference genes are referred to as internal controls. And basically what these are genes that are turned on all the time. They're called housekeeping genes typically. And they're turned on at a fairly reliable level. So they use these to determine what the relative expression level is of the cancer-causing genes or the prognostic genes. I'm not crazy about using internal controls. It's commonly used in RNA. I prefer to use a completely separate negative control from different tissue of a person that doesn't have cancer. I think that's a much more accurate way to go than an internal control, because internal controls can be all over the place. Now, the way they get around that is they use 5 of them, not just one.
Right.
So the 21 genes are comprised of genes involved with proliferation, Ki67, that is a common one, STK15, BERT5, CCNB1, and so on. It's also got metastasis-related genes, and then it's got HER2-related genes, and then sex hormone-related genes, and then obviously the internal control.
Okay. I do feel compelled to just add a little thing there about what you were saying earlier about your preference for the expression testing. Folks watching at home, it's important to understand that RNA is highly conserved across our species and from kind of region to region in the body. So that's why it would be an appropriate thing to do in terms of using someone else's tissue that we know doesn't have cancer, rather than your own. We have a whole video on RNA expression testing and how it all works. I'll link that beneath this video for you, so you can have a look into that. But that's why, is that accurate, Alex? That's why you're...
Yeah, totally. Yes, yeah. And I mean, we've taken, for example, we've taken brain tumor samples from 3 completely different patients without a brain tumor, normal positive controls, and the expression across the 21,000 gene panel we looked at is remarkably close. I mean, we can look at these expression values as almost within 1 or 2 fold difference from each other, and many times very much the same, like accurate. So yeah, it's very stable across different. I mean, obviously, a certain level of expression of certain genes creates a certain tissue.
That's right. That's how it works.
So
yes. To RNA. So the concern with using your RNA when you are known to have cancer is that it might be a little funky. There might be something off.
Exactly. Yeah.
So that's why we prefer to use tissue from people who we know don't have cancer to compare yours to. Anyway, for the interruption.
So we'll start with pre-menopause patients. If you have a stage 1 to 2 ER positive breast cancer and are 50 years or younger, assuming you don't have an early menopause, 0-15 means that you have a low risk of disease recurrence if you get aromatase inhibitors, and there's no benefit from chemotherapy. A score of 16 to 20 means you have a low to medium risk of disease recurrence if you get an aromatase inhibitor. There may be a small benefit of receiving chemotherapy, but typically the benefits do not outweigh the side effects. Then if you have a score of 21 to 25, means you have a medium risk of recurrence. If you get aromatase inhibitors, the benefits of chemotherapy are kind of on the border here. They may outweigh the side effects. And then anything 25 or above 25, 26 to 100 means you have a high risk of disease recurrence, and both aromatase inhibitors and chemotherapy should be used. Now, we can talk about that in more detail later, but there's going to be a variety of different factors. I suspect the main factor here is going to be the Ki-67. If Ki-67 is high, that means your cancer cells are constantly reproducing, and chemotherapy typically works on cells that are rapidly reproducing. That's a mechanism. So if you're post-menopausal, and you have stage 1 to 2 ER positive breast cancers, so 50 years or older, assuming you're postmenopausal at 50, that can change, obviously. A 0 to 25% or a 0 to 25 score means you have a low risk of disease recurrence if you get an aromatase inhibitor, and a low chance of benefit from chemotherapy. If you have a 26 to 100, that's a high risk of disease recurrence, and both aromatase inhibitors and chemotherapy may provide benefits. Now, we're going to discuss that in a little more detail as we move forward.
Okay.
So here's a nice little flow chart of how this test can be used. I like these sort of flow charts. I got this one from Neil Love's Research to Practice. As everyone knows, I'm one of his biggest fans. I love what he's doing. I think he's doing amazing things for cancer and educating doctors and moving things forward. And the RS number is a score, as you can see. So you'll notice in this one, it says node positive, premenopausal node positive, 1 to 3 lymph nodes, and there's no score there. So I'm going to talk about that in a minute. A test came out called the TAILORx trial, where they wanted to see if they could use the Oncotype in different cases. So women that did have lymph node metastasis. Okay. Now, what they did was they did confirm women with ER positive, HER2 negative, axillary lymph node negative breast cancer, treatment with chemotherapy and aromatase inhibitors after surgery is no more beneficial than treatment with aromatase inhibitors alone. This is an interesting finding because obviously the Oncotype DX score above a certain level says, definitely chemotherapy can be a benefit. But really, what is that benefit? And that benefit is quite small. So in this particular study, what they found is that chemotherapy can be avoided in women older than 50 with a recurrence score of 11 to 25, at any age with a recurrence score of 0 to 10, and 50 years old or younger with a recurrence score of 11 to 15. Now, in chemotherapy may provide benefits for women at any age with a recurrence score of 26 to 100, and 50 years old or younger with a recurrence score of 16 to 25. So this is a nice little graphic that I got from Neil Love's Research to Practice. I thought this is really a cool looking graphic because it's changed a few things. What we see here is ET means endocrine therapy, and CET means chemotherapy. And then at the top, we have the lymph node status. So N0 means no lymph nodes, N plus either 1 to 3 lymph nodes, and then N equals 4 or more lymph nodes.
Okay. And the CET means chemo and
chemotherapy. chemotherapy. Chemo and endocrine therapy together. Yeah, sorry. Thanks for clarifying. So we have premenopausal and postmenopausal. What is interesting here is if you look at the N0, you'll notice that in the 16 to 20, we have endocrine therapy for low risk, and then we have chemotherapy and endocrine therapy for high risk in the premenopausal. So that's this area right around here. So that's changed. That's a new thing now, and that's new since the 2022 San Antonio Breast Cancer Conference that used the Oncotype in different settings. Obviously, there's many different studies and so on doing this. So you can see the chemotherapy in high risk here. How do you define high and low risk? Well, there's a bunch of different ways you could define that. And so I guess what this really shows is that an Oncotype DX test is not everything.
Beyond not everything. It's
exactly.
Very
it's a great way.
It's a great way
to look at. Yeah, it's a great way to look at risk, but you have to look at other factors too.
Yeah.
Okay. So there's some disadvantages of the Oncotype DX. So it uses a tumor block without actually isolating the tumor cells. And anyone who's got experience with pathology and tumor DNA sequencing and RNA expression testing knows that you're going to get a bunch of other things in there if you're not using laser LCM.
Laser microdissection.
Laser microdissection, yeah, using which is a great tool, a really great tool for isolating tumor cells and starting your testing on a sample of purified tumor cells. I have to wonder how the data would change had they used LCM, but obviously it's not feasible, cost factors and so on.
Yeah. For those of you who aren't as familiar as Alex is with tumor sequencing, what he's saying is the tumor block is the surgical remnant or biopsy sample that comes out of your body and goes to the pathology lab. It's got normal cells, got blood plasma, it's got all sorts of stuff in there in addition to your tumor cells. And it's very common for proper sequencing, if they don't use laser microdissection, to fail. Actually, statistics show they fail about 40% of the time, because a lot of the time what's getting put into the machine for testing is not your tumor cells, it's normal cells, or it's a mishmash of the two, and so the results are confounded. So that's what Alex is referring to here, is just taking your tumor without making sure they isolate just the tumor cells and take all the healthy cells and plasma and all the other stuff out, you're going to get a confounded result. And so that's always a concern with any sort of tissue testing, but especially in this case.
Yeah, I think the failure rate is more due to the fact that the DNA is too degraded and DNA, there was not enough of it. But yes, you get spurious results when you include a bunch of other cells and not just tumor cells. The other thing that's really important, and we're seeing a lot of this now in different studies and different approaches, is this test is not as accurate for Black women, African American, as it is for non-Hispanic white women. And this is due to relatively few Black women participating in the studies that were used to validate the test. We know that Black and African American women typically have a very high score. They're often above 25, and so we're not sure how that fits with them. Also, and this is kind of important, is that the test does not appear to add significant additional information to inform treatment decisions for patients with low estrogen receptor expression. And this can be a real problem. So if you have low estrogen receptor expression, you already have a worse negative prognostic outcome. But the Oncotype test doesn't really work very well, and often these patients have a score of above 25 regardless. Now, it's important to understand Oncotype DX does not replace tumor DNA sequencing. Tumor DNA sequencing is used to identify what sort of genetic alterations have been found. And this is really important because there's many targeted therapies for breast cancer now. And when I say targeted therapies, I'm referring to CDK4/6 inhibitors. I'm referring to drugs that target HER2 mutations. I'm talking about drugs that target estrogen receptor mutations, drugs that target PIK3CA mutations, drugs that target AKT mutations and PTEN mutations, HRD status for PARP inhibitors, RB1 status, P53 status. P53 can determine whether alpelisib, a PIK3CA inhibitor, is going to work very well. And of course, your BRCA1 and 2. HRD, BRCA1 and 2 is part of the HRD. But PARP inhibitors can be a significant benefit. So getting tumor DNA sequencing can tell you what drugs are going to work for you and what other targeted therapies are going to work for you that are not, that may not be the first line of choice. And importantly,
they might be your first line of choice patient, but they might not be your standard of care cancer agency first line of choice.
Yeah, exactly. Yeah. In other words, they're available drugs. It's just when to use them is not always confirmed, because tumor DNA sequencing is not done in breast cancers or early stage breast cancers. And importantly, tumor DNA sequencing can also identify mutations that will prevent specific drugs from working. So, I've seen patients with low Oncotype DX scores that have their tumors occur very quickly. And these patients often have like estrogen receptor mutations or PIK3CA mutations. And if you scroll back, you'll see that PIK3CA, all of these mutations alter the way the gene functions. And basically, these mutations can cause the genes to get stuck to their partners and, in an effect, result in something called constitutive signaling. Whereas overexpression, which is what the Oncotype DX looks at, just tells you whether the gene is turned on or off. It doesn't tell you whether it's mutated, if it's got a different function. So very different roles here. So we did a video on how to tell a good tumor DNA sequencing test from a poor one. There's many different companies offering great tumor DNA sequencing tests. We have our own panel that is one of the most expansive and most detailed. Yeah, it's a good video, I think.
Yep, I do too, because there's so many tumor DNA sequencing tests out there, and we love that patients want to be well educated. It's so important for you and your family members to understand, but there's a lot of confusing info. We talk with oncologists like almost every day, or engage with oncologists almost every day, who don't themselves understand tumor DNA sequencing, how and when to use it, and how to tell whether a test has merit or not, or how to read the results. So it's confusing for the folks who are supposed to know this stuff somewhat, let alone for you at home when your life is on the line. So we've created this video so that you can have a little checklist for how to tell, is this a good test or is this not a good test? Should I use this one? Because it's important that you get the most accurate and thorough diagnosis as soon as possible. So Alex, I have lots of questions that I think the folks at home might as well.
Okay.
I'll work backwards. So if the I just want you folks to know, if the Oncotype, if it is an expression test, as we were talking about earlier, of 21 genes, and specific to your relevant,
16.
Oh, well, 16 plus the 5 controls.
Yeah.
So this is the difference between Alex and I, okay? He's a scientist and I'm a general. So we've got this overexpression of these 16 plus 5 controls done with the Oncotype, looking to see specifically whether a type of endocrine therapy or chemo is right for you. Right now, today, 2024, you can be tested for 20,813 genes, not just 16, to identify the relative expression and for their involvement in your cancer, and get started sooner on the right therapy. So understand the vast chasm between 16 and 20,813. Just saying, what I want to do for each of these categories, if you're willing, is just like, what should these people do? Like if you're at 0 to 15 and it says no benefit from chemotherapy, I want you folks at home to understand that doesn't mean there's no treatment for you. It doesn't mean that there aren't excellent targeted therapies or other drugs that would benefit you. So in cases like this, Alex, what would you suggest that somebody who might end up with this type of score from Oncotype DX do?
Well, I think this is somebody that definitely probably has a fairly good prognosis. I think the Oncotype is pretty good at detecting that.
Okay.
Really, the benefit of chemotherapy in estrogen-positive breast cancers at the best of times is really small. It's like 3 or 4%, even in patients that have a high risk score.
Okay.
And this is what we really found from studies like the TAILORx.
Okay.
So yeah, so the chemotherapy is really being used less and less.
Okay.
And this test is really just designed to say that your cancer is really not growing that fast, or
Okay.
is growing fast. And it doesn't necessarily mean that chemotherapy is the right drug for you. If you have a high score, you probably want to be looking at some of the newer, well, you want to make sure that you don't have mutations in any of those genes. So, I mean, the first number one thing you need to do, regardless of what type of cancer you have, is get tumor DNA sequencing.
Okay.
Because if you're taking endocrine therapy and you have an estrogen receptor mutation, it's going to be a waste of time.
Okay.
There's specific drugs for that purpose.
Okay.
If you are taking, and if you're told you have a low chance of recurrence and you have a HER2 mutation, that HER2 mutation can kick in and create a subpopulation of cells that is going to be completely treatment resistant.
Right.
So, the tumor DNA sequencing at any level, at any stage, is the most important thing.
Okay.
This is really just to tell you what the chance of benefiting from chemotherapy and endocrine therapy.
Yeah, and I guess that's just the point that I wanted to make, whether for this category or the categories in the next two slides.
I like this one from you. I think this is a really nice one.
Sure.
It really explains everything.
Okay, but it all, again, what I'm really just trying to convey here to you folks at home is there's so much more than chemotherapy. And there's so much more than endocrine therapy, and you require the proper tumor DNA sequencing to identify what that is. So if your doctor says you're low risk, go home, you don't need to do anything, or you'll die of something else before you die of cancer, or those kinds of things that they say, do not be lulled into a false sense of security. Please get tumor DNA sequencing. Understand with confidence, your life literally depends on it. And the sooner you identify any targetable mutations or any possible problems, like certain mutations that might prevent that endocrine therapy from working, the faster you can get on the right therapy, get that cancer gone and back to your life. So, I guess what we're saying in summary here is the Oncotype DX is for a small subset of people. There's lots of things that are a little confusing or a little confounding about it. And again, it's more specific to chemotherapy. And most people these days don't really want chemotherapy, or that's not the treatment that's going to provide you with the greatest benefit. The reason why this test is still used and so popular is because it's cheap. It's already within your public healthcare system. Doctors are familiar with it. And sadly, a lot of patients get confused and they think that Oncotype DX is thorough genetic testing. And the main reason I wanted Alex to make this video for you is so that you understand the difference now between what this test actually is and what it's telling you versus what's possible. The best tumor DNA sequencing panel looks at 550 known cancer-related genes. Again, there's an RNA expression test that looks at 20,813 genes. That is a proper diagnosis if you have cancer. This is just maybe telling you if chemo will work or not. And
I think what you're trying to say here is what is the weight between an Oncotype DX test in determining treatment options and tumor DNA sequencing? And they're not even in the same planet. They're not even in the same stratosphere. It's completely different things. And tumor DNA sequencing will allow you to take advantage of the new targeted therapies and determine whether you're going to respond to them or not respond to them. And that's the most important thing. Oncotype DX is just a prognostic score. It just tells you your risk of having your cancer recur and whether chemotherapy can reduce that risk of recurrence. That's it.
Yeah, but there are drugs that are so much more effective that are not chemo. So anyway, enough about that. I hope this was really helpful. I hope it's clearer than mud for you. Please post your comments, send us an email, ask us your questions. That's what we're here for. You can book a 1-hour consultation with Alex. He'll review your records, look at all possible treatment options available for you, and then meet with you on Zoom to discuss, give you a written report. You can join our free online education and self-advocacy training program. We have regular Zooms, so you can ask your questions directly. And then, of course, subscribe to the YouTube channel, stay informed, new videos every week. If there's something you specifically would like us to make a video about, tell us all about it. We are responsive. Thank you for watching. I hope this has been helpful.